Hello and welcome to the next instalment of our Arthritis Ireland conversation series, Living with Lupus. I'm Gráinne O'Leary, Chief Executive of Arthritis Ireland. Our mission in this series is to bring you up-to-date information on a range of arthritis and related conditions and treatment and management options. During these episodes, you will hear from expert voices from across the medical spectrum, as we strive to answer some of the more common questions you may have and to gain some insight into the latest medical research relating to these conditions and treatments. Today I am joined by Dr Laura Durcan, Consultant Rheumatologist at Beaumont Hospital and Associate Professor at the Royal College of Surgeons. So thank you so much for joining us today, Laura.
No problem, Gráinne. Thanks for hosting this. It's really exciting for me to come talk about my favourite topic.
So, on the topic of that, I'll start by asking you, can you tell me exactly what lupus is? Are there different types? What are the main symptoms?
Sure.
Let's start there.
So for every person who has lupus, it's a little bit different to the next person. So it's not the most straightforward definition, but essentially every patient who has a diagnosis of lupus will have some form of antibody. So that's an immune-mediated marker for cellular damage. And so and the patient's own immune system is then triggered to attack their cells. Now, in some people, what that will look like is it'll look like arthritis. In some people, it will look like inflamed skin and skin disease. In some people, it will be nephritis or kidney inflammation that they will have predominantly. In other people, it can be brain and nerves that are inflamed. And there can be a whole host of combinations of those different areas of inflammation. In addition to that, some people can have markers for autoimmune blood clot formations, and those people will have a different manifestations of disease where they perhaps present with blood clots or pulmonary emboli. And really, no two people's lupus looks exactly the same. It's differing combinations of antibody profile with the clinical manifestations or what it is they complain about. And the diagnosis is made on what are called classification criteria. And there are loads of different types of classification criteria that have been developed over the years. It's such a complex area. But essentially, patients usually have evidence of immune dysregulation. So they'll have antibodies detectable in their blood. And then they'll have a clinical manifestation associated with that. So you'll have antibodies, and then you'll have evidence that those antibodies are causing harm or are doing something within the patient's system. So those combination of the two things, so the antibodies and clinical disease is usually what it looks like, but for no two people does it look exactly the same, which makes it a little bit difficult for people to diagnose it, firstly. It makes it a little bit difficult for people to run clinical trials in it because it's not just one disease, it's a whole host of different autoimmune phenomena that cluster together. And it makes it very difficult for the patients to describe their experience. And often they've had a long road in getting to their diagnosis, getting on their medication. So there's loads of reasons why I'm delighted to talk about it today, but it is a very broad church of people with autoimmune disease.
Okay. And do we know what actually causes it?
So we know that people have a genetic tendency. So they might have something in their genes that flags them for having autoimmune disease. Loads of people have autoimmune disease in their families, say be it thyroid disease, type 1 diabetes, other autoimmune things. And so you have a person who's kind of primed for autoimmune disease. And that's probably about 30% of the risk of developing overt lupus. And then the second 30% are the exposures that you encounter in your life. So be they environmental toxins or exposure to viruses, different things that you encounter over the course of your years that then prime your immune system for attack, for want of a better word. And then the third kind of 30% of your risk factors for developing systemic disease are totally unknown. We know that the antibodies can be detectable in your blood for a long time before you ever develop symptoms or before you ever come to medical attention. So when they looked back on people who had a diagnosis of lupus and they went back on old blood tests that were stored in different health systems, they found that those blood test abnormalities were often present for many years before they became kind of problematic to the patient. So it's the primed immune system, environmental influences, and then plus something else that we don't really understand. And even in the setting of, say, for example, identical twins. So if you and I were identical twins and we shared absolutely identical genetics. We are mirror images of each other. The risk that we would both have the same disease is only maybe 30%. And so all of those other factors are things that influence us over our lives, and they kind of equal what it is we develop or the disease.
They play a bigger role than genetics?
Yeah, well, it's multifactorial. So it's loads of things feeding in. It would be really easy to diagnose a disease if there was just one gene that you test for and you say, well, you have this gene. You know, now obviously a lot of those are terrible diseases, but you know, you have this gene. We know what this gene looks like. This is a very defined entity, whereas lupus is some genes causing some antibodies, interacting with the world, interacting with your organs, and bringing you to the doctor. So it's a much more complex.
Yeah. And if another just add-on question I would have is about ethnicity. Does that have a role to play?
Yeah, so it's really interesting. So, and I think sometimes we've been a little bit slow to talk about the fact that we're not all exactly the same in how we're made. And there are definitely differences in terms of our kind of genetic makeup and what diseases we get. Like we see lots of hemochromatosis in Irish people, and we see lots of genes for cystic fibrosis in Irish people, and in white Irish people from Ireland. Obviously Irish people look a lot different now, but you do see different spectrums of lupus in people who have non-Caucasian skin. So now that's not to say that people who are fair-skinned can't have terrible lupus, but you do see in non-Caucasian populations, you see more nephritis and you see more thrombosis in those populations. And so it is a disease that can look different in people of different genetic origins. And I suppose the other thing to highlight, and this is a little bugbear of mine, is that lots of the autoimmune rashes and rheumatic rashes that we see that go along with autoimmune diseases, they look completely different in brown skin. So all of the medical textbooks over the years have been mostly based, any of the photos, on what, say, psoriasis or lupus or discoid lupus, dermatomyositis, what all of those things look like in white skin.
Yeah.
And so a lot of those things look quite different in people who have pigment in their skin. And so there is a movement now to kind of try and bring in medical teaching around skin of colour. So I think our newer generation will be better at that. But it's another thing, I suppose, that compounds this, is that often the autoimmune rashes can look kind of different in people who are non-white.
So you're really building a picture there of a very complex disease. So how do you arrive at a diagnosis? I mean, obviously first you need people to be referred to you, but there's obviously a pathway and steps that need to be taken along the way. So can you talk me through that?
Yeah, so I would say that medicine nowadays is much, much, much better at diagnosing this. And some of this probably comes from, I don't know if you ever watched Dr. House.
Yes.
So it was like, oh, it's not lupus. And actually that has probably triggered a generation of doctors to actually know what lupus is. So I suppose I'll start with the distinction between cutaneous lupus. So there's and systemic. So I might just describe that a little bit. So if you have lupus skin disease, so lupus can you can have quite a lot of inflammatory rashes, but your lupus can sometimes just be a skin disease. So no evidence of systemic involvement. And often those patients will have maybe one or no antibodies shown in their blood, and they have inflammatory skin disease that looks like cutaneous lupus, which is skin lupus. There are loads of different forms of skin lupus, but the most common ones we see are ones that are called discoid lupus. So discoid lupus, it's called discoid because often it forms a disc shape, and it is quite a scarring and deforming type of rash. It can sometimes cause areas of hair loss on the head, which would be circular and look a little bit, for all intensive purposes, like ringworm, that kind of thing, those circles. And that is often treated quite aggressively because that can scar and leave people with quite a significant amount of disfiguring rashes, like be it on their head or on their face, very commonly triggered by ultraviolet exposure. So the sun is one of the major triggers, if you're going to look at the environment, that will bring out inflammatory skin lesions. So we know that if somebody has one of the antibodies called the Rho antibody, which is commonly found in lupus, Sjogren's, rheumatoid arthritis, a little bit less commonly, but it's there, sometimes in women with thyroid disease. If somebody has a Rho antibody, they tend to be quite sun sensitive, and they will get either they can sometimes get malar rashes, they get discoid lupus, subacute lupus, which is a more widespread erythematous rash from the sun. But the sun can be a real trigger for skin lupus, be it with or without systemic involvement, if that makes sense to you. So one of the first things that we talk about in people who have a diagnosis of lupus is that the sun is not their friend. And oftentimes the patients themselves will have come to that conclusion themselves. So they will often say that they feel absolutely awful, that they're drained, that they're miserable. Even if they don't rash up in the sun, they'll say, listen, I haven't stuck my head outside for years. I feel terrible. And it's part of that really interesting paradigm where the ultraviolet exposure to their skin causes this antibody in their system to become activated and start to damage them. And so oftentimes my patients will have recognized themselves that the sun is not their friend and they'll have avoided it. But we say they need to wear a hat when they're outside, factor 50 head to toe, 2 layers of clothes. It's sunny. In Ireland, you probably don't need 2 layers of clothes.
But in a sunny environment.
2 layers, double layers.
Really? Yeah.
It's the one thing that you'll say is that people don't tend to get those rashes underneath their underwear. Because your underwear is the one place where you definitely, unless you are making unusual clothing choices, will have 2 layers. And so you don't tend to get any ultraviolet mediated rashes in those places. So we would say if you have a sun sensitive rash, you double layer, SPF 50 head to toe and a nice big hat. So I suppose that's the skin type of lupus. If we're going to move on, and oftentimes that's what is the first thing. So I've had lots of people coming into me and their first manifestation of lupus is that they present with, say, a malar rash, which is the rash across their face, and they say, I feel terrible, my joints are sore, I'm fatigued, I'm lethargic, I'm not right. And often that will trigger their GP to send off autoimmune blood tests. And one of the biggest changes in medicine over the last 20, 30 years is that these blood tests are widely available and they're sent all the time from GP practices all over the country. So that's where somebody sends an ANA, which is an anti-nuclear antibody. And if that's positive in the laboratory, that will trigger them checking the more specific antibodies for lupus. So those are anti-double-stranded DNA. And if those are positive, generally speaking, our referral will start to make its way towards a rheumatologist.
Right, okay.
The rheumatologist then will want to check complement levels, which are measures of whether or not you're an antibody maker, and they kind of give you an idea of whether or not you're making an immune complex reaction to something in your system. Check your urine, because you cannot feel kidney inflammation, and then do an assessment for arthritis and the other manifestations associated with lupus. But the first thing, I suppose, for the patients is that they will present with a symptom. They will present to their primary care doctor, and it's that they generally are really good at sending off those immune blood tests. So that tends to be the first step in getting as far as me.
And you mentioned, you spoke a good bit there about the cutaneous form of lupus. When it comes to SLE or lupus nephritis, are they sort of different disease types within the lupus family? Or is there overlap?
So if you have isolated skin lupus, I'm kind of going to put you in a little bubble all by yourself. I'm going to talk about those people first. So people who have isolated skin lupus generally will be prescribed hydroxychloroquine, which is Plaquenil, which is the drug that former President Donald Trump wanted us all to take for COVID, which does not work for COVID, but is a really good drug for skin inflammation and is also really good for people who make antibodies and kind of subtly modifying the immune response. So if you're prescribed hydroxychloroquine, that is a good skin inflammation drug. It's also really good at preventing you from moving out of that category into developing inflammation of other organs. So Plaquenil would be the cornerstone of therapy for those people. Sometimes their skin becomes more problematic and they end up graduating to other immune suppressive agents, but they start with hydroxychloroquine. The really important thing for people who have skin inflammation is firstly that they need to avoid ultraviolet exposure, and secondly they need to stop smoking. Hydroxychloroquine doesn't work in smokers. And so often discoid lupus in particular will crop up in people who smoke. And so one of the things that we really kind of try to impress upon our patients who have discoid, which is a horrible, disfiguring, miserable rash, is that, you know, taking your tablets, avoiding ultraviolet exposure and giving up the cigarettes, that will get a lot of them quite far in terms of settling down their skin. So I'm going to put them into that.
Can smoking be a trigger?
Yes.
It can be. It can actually trigger the disease.
Yeah.
Yeah. So like other autoimmune.
Exactly. Yeah. So we'll put the skin lupus people off to one side, and that's generally the pathway that they go on. If that doesn't work, they will graduate to the other agents that I'll talk about, but mostly that's where they sit. People who have systemic involvement for lupus, it does look different for each person. So I might talk about the manifestations separately, acknowledging that in some people, they will fit into 3 or 4 different pots. So, for example, if you have inflammatory arthritis and you also have nephritis or inflammation of your kidneys, you could also have something else that goes along with your lupus. We tend to try to get a kind of a 2-for-1, where we treat all manifestations with the most appropriate available drug. So, but for each person, the combination, like Tetris blocks, can look a little bit different in terms of what their disease is. So I'll talk about each manifestation first, but the people who are watching this, they may have bits of one and bits of another, and for them, they may be a little bit different to the next person. So I'll talk about the arthritis first. So lupus arthritis can look very similar to rheumatoid arthritis and can be treated very similarly to rheumatoid arthritis. There's a second, and that's kind of a...
And is it a different subset to rheumatoid arthritis, the type of inflammatory
They
that
do see synovitis, so you can get inflammation in the joints, and in a rare number of the people, they can get erosive change that looks almost indistinguishable from rheumatoid arthritis. But the classic arthritis that is described in lupus patients is a thing called Jacquard's arthropathy. And Jacquard's is, I gotta say, like, this sounds so lame, but Jacquard's is quite a cool type of arthritis. So unlike rheumatoid or psoriatic arthritis, Jacquard's will have bone preservation. So their x-rays will be normal. And we think that Jacquard's relates to inflammation of the supporting ligaments throughout the hands. And what we see is a drift at the knuckles where the fingers drift outwards. In the case of rheumatoid, where you see drift to the side, you can't generally bring it back in. So the rheumatoid patients who have deformity tend to be stuck in that position. Whereas lupus patients who have deformity, because it relates to ligamentous laxity rather than to arthritis per se, you can pull them back in and straighten them.
Okay.
And they tend to be functionally quite good. So in patients who have patterns of arthritis that look very similar to rheumatoid arthritis, we follow a very similar treatment paradigm. So that would be, often we start with methotrexate, and then we build on that according to how the patient responds to that therapy. The good thing about methotrexate in lupus is that you do get a little 2-for-1 out of methotrexate. So methotrexate is great for skin disease, covers that very well, covers the joint disease. But actually you start to run into difficulty if the patient has also got nephritis or kidney inflammation, because that puts us in a whole different trajectory in terms of their treatment. Now, if you were to have inflammatory arthritis with your lupus and kidney disease, often rituximab will treat that combination.
Okay.
And rituximab is quite good at skin. So you can see how you kind of end up picking your therapeutic strategy according to what combination of symptoms the person has. So the arthritis, I suppose I'm going to put that in one bucket there and say we treat the synovitis and the inflammation that we see. Jacquard's arthropathy is not one that historically responds very well to immunosuppression. That said, it doesn't tend to be that bad. And patients tend to maintain the function in their hands. They don't tend to have a big problem with it.
Okay.
But the arthritis that looks like rheumatoid, we treat in a very similar fashion to rheumatoid, with the exception of avoiding TNF-alpha inhibitors usually. That's the arthritis. We're going to go to nephritis next. Yeah. So kidney inflammation is really common.
That's what nephritis is.
Absolutely. So people who have a diagnosis of lupus over the course of their lifetime, about 60 to 70% of them will have evidence of nephritis over the course of their disease. So it's incredibly important that we screen for that, because nephritis is the one thing that a patient won't feel. So they won't come to you and say, I think my kidneys are
Yeah,
inflamed.
they don't have any
feel it.
symptoms?
They don't feel it until all of a sudden they're holding on to fluid.
Sure. Okay.
And they'll arrive in like a big swollen balloon, and they'll have been losing protein from their kidneys. And so what we see in nephritis is on a simple urine dipstick, which can be done in a GP's, usually done for infection, it will be blood and protein that we see on dipsticks that indicate that perhaps the kidneys are inflamed. If we see dipstick positive urine, so urine that shows blood and protein, we then send it off to the lab and they give us a number as to how much protein is the patient is losing. If the patient is losing more than 50 micrograms of protein per 24 hours, it's the urinary protein creatinine ratio, that would trigger us to considering whether or not we need to do an ultrasound of the kidneys. And if we think they have nephritis, we diagnose it with a kidney biopsy. A kidney biopsy is a small needle into the patient's back, which is done with an image-guided ultrasound guide. We take a sample of the kidney and we send that to the laboratory. There are a couple of reasons why it's important, if we think the patient has nephritis, that we firstly diagnose it, because lots of the treatments that we use for nephritis are almost similar to chemotherapies, and you want to know that your diagnosis is right. That's the first thing. The second thing is that there are lots of different types of lupus nephritis, and we tailor our treatment slightly differently depending on what type of nephritis they have. And so we need to know the class of lupus nephritis. We need to diagnose the lupus nephritis. We need to know the class. And then we need to know how healthy the nephrons or kidney kind of mechanisms around the inflammatory infiltrate are. So how healthy are the underlying kidneys? And once we've diagnosed the lupus nephritis using a kidney biopsy, we then follow the urine protein creatinine ratio and the creatinine to see whether or not people are responding to therapy. So the creatinine is the blood test that you will take. So say if you're getting your liver function test, your kidney function test, your kidney creatinine will be the number that people follow to say the sponge is looking good, your filter is working, this is fine. The protein will tell us whether or not the sieve itself is intact. Okay. So if you have leaky membranes, you're losing loads of protein, it implies that you have ongoing inflammation in your kidneys. And so when I'm targeting therapy to somebody who has lupus nephritis, I'm following that urine protein to see whether or not the inflammation in their kidneys is settling down. And we follow that really closely while we're treating the nephritis. We want to get it as tight as possible because we know that that equals good kidney outcomes. That makes it more likely that our patients won't end up on dialysis, won't develop chronic kidney disease and all the complications of that. Now, the treatments that we do, so I'll roll it back to where we've got our patient, she has a positive dipstick, she has urine protein creatinine ratio of greater than 50, and we're saying we're going to do our kidney biopsy. We do our kidney biopsy, we diagnose, say, class 3, class 4 lupus nephritis. We then have to have a conversation with her, and I'm saying her because most of them are women, but I acknowledge that
I'm going to ask you about that.
There are lots of men out there who have lupus nephritis.
Yes,
see me
I
in
will
clinic.
be asking you about that.
I'm not, and they are also very precious to me, so I'm not disregarding them. But for the most part, these are women. We then have a discussion regarding how we're going to treat the nephritis. Now, the treatments for lupus nephritis, we'll have the person on hydroxychloroquine because we'll have started it when we've diagnosed their lupus. And if we haven't, we'll want to get them onto hydroxychloroquine or Plaquenil because that's kind of our cornerstone drug that's floating in the background. Unless there's a reason for it not to be there, it's there. And then generally speaking, unless their lupus nephritis is very inflamed or there's other features to suggest we need to go more aggressive, we usually start on a drug called mycophenolate mofetil, which is Cellcept. Now, Cellcept is one of my favourite medications. It does a phenomenal job of controlling lupus nephritis. It's a really great medication. There are a couple of downsides. So mycophenolate cannot be prescribed if somebody is planning pregnancy. It cannot be prescribed in pregnancy, and it's known to be teratogenic. So that's a big red. When I'm giving somebody the mycophenolate talk, I'm like, I want you on contraception. And yeah, generally people take their contraception in the same way they take their medications. It's not a big deal. But I really, really don't want, and I get the call about once a year that one of my patients who's on mycophenolate is pregnant. I'm like, oh my God. And thank God I've never had any adverse outcomes from that, but there are horrendous birth defects described in those. So it's a real bugbear of mine. Rituximab, which we use for which we can use for arthritis and other manifestation, that's there in the background. That has some data for lupus nephritis. We often will use it. And if we're up against the wall, we go with a medication called cyclophosphamide, which is a chemo medication. So cyclophosphamide is kind of where we are go-to if we have somebody who's either very, very sick from their nephritis or very sick from another component of their lupus, or if our previous medications haven't worked and we haven't managed to get type disease control. So cyclophosphamide started life as a chemotherapy agent, and generally speaking, from the perspective of rheumatology, we give it intravenously. So patients will get it into the vein, usually for a short period of time, sometimes 4 to 6 months, that kind of thing. And then somebody will graduate to maintenance therapy once things settle down and they have had their cyclophosphamide. It's a great therapy, but again, it's teratogenic. So we can't prescribe it to women who are pregnant or who are soon planning pregnancy. And the second issue with cyclophosphamide, and this is the one that kind of, that people, it often can be problematic in, is that it does diminish your fertility over time and it can cause a premature menopause. And so oftentimes my patients will come in with nephritis and they'll have had their babies and they don't actually really care about their future fertility prospects. But often there are people, and in particular, if you're thinking about, we're giving cyclophosphamide to women in their 30s, that's when it starts to have an impact on their fertility. The younger patients in their 20s and teens, we don't see the same big impact on it. And so for that reason, and for other reasons, it's a chemo, we see low white cells, we see infections. We do keep that in our back pocket for people who have severe disease, generally speaking. So
does it reduce male fertility as well?
Yeah, so for it does. And so there's a lot of, it has to be the best drug for the patient, and there has to be kind of clear communication regarding why you're choosing that agent, why it's the best medication for that person, so that you can come to a good decision. There's absolutely no point, I suppose, from the patient's perspective in saying, I don't want that medication, if it's all you have and you're going to end up on dialysis without it. And so there is often a kind of a quid pro quo there where you say, you know, your ovaries and your future fertility are really important, but equally staying alive right now and keeping your kidneys is also important. So it can be challenging because those people are very sick and they've had a hard run. But that would be the next line. I'm going to move from the kidneys then to the blood. So we see lots of blood test abnormalities in people who have lupus. So some people have low platelets because their immune system eats up their platelets. Some people have low white cells because their immune system eats up their white cells. And some people have low hemoglobin or hemolytic anemia where their immune system eats up their red blood cells. And so those are the major kind of autoimmune components that we see where the lupus attacks red blood cells. And generally speaking, immune suppressives are the treatment for that. And oftentimes those patients end up getting quite a lot of steroids for their blood abnormalities. Hematology will usually help us mind those patients, the same way nephrology will often weigh in on the nephritis patients. So the next group that I'm going to talk about are people who have inflammation of their internal organs. So serositis is the word for that. And that's inflammation of the lining of the internal organs. So you can get serositis involving the lungs, which would be pleurisy, where patients tend to get a kind of a pain when they breathe in as the pleura rub off each other because they're inflamed. Get serositis in the abdomen where people present with abdominal pain. You can get, essentially, it'll be any of the internal organs that have a lining can become inflamed. The most common one, though, is that patients present with chest pain. Oftentimes that will trigger people to get a thing called a CTPA because we always worry about blood clots in these patients because some of them will have sticky blood from antiphospholipids. But pleurisy is really common in my lupus patients. And again, sometimes it's a short course of steroids to settle that down, and immunosuppressives will be needed if it's a recurrent thing where people have inflammation of their lungs. I suppose that leads me then to the sticky blood problem. So antiphospholipid syndrome was first described in patients who have lupus. So antiphospholipids are antibodies that are in the blood that cause thrombosis or clots. We now know that you can have antiphospholipids in the absence of lupus. We know that you can have them sometimes with rheumatoid. And in the setting of lupus, they're another kind of blood abnormality and clinical outcome that we count when we're coming to our diagnosis. If somebody has a diagnosis of APS or antiphospholipid syndrome, it's generally because they have had a thrombotic event or a clot in the setting of positive antibodies being found in their blood. And for those people, the blood thinner that they have to be on for the long term is warfarin. Again, warfarin becomes problematic in women of childbearing age because warfarin's a teratogen. So for the duration of pregnancy, those patients have to be changed onto low molecular weight heparin, which are injectable blood thinners. And so, yes, just another kind of layer.
Do any of the newer therapies, I mean, I know warfarin's been around, do any of those actually, are they appropriate?
Yeah, so there are, so anyone will know warfarin clinics used to be the busiest place in the hospital.
Yes.
And now over years, warfarin has become really uncommon actually. Yeah. So warfarin is used now for people who have valvular atrial fibrillation, so atrial fibrillation with bad mitral valves. It's used for people who have metal valves. And it's used for my patients with APS. And those are the only, like, they're the main categories of patients who are now in the warfarin clinic. So they did some studies looking at the new checkpoint, or the new blockers for, which are used to treat DVTs and can be used to treat atrial fibrillation. Yes. And they're not adequate in preventing thrombosis in antiphospholipid syndrome. And so what they think is that, so warfarin, the coagulation cascade or the sequence of events that have to happen for a clot to be made, the newer agents, they inhibit that at one point. But warfarin inhibited that cascade at multiple points. And it seems that patients who have positive antiphospholipid antibodies, they need multi-point inhibition of their coagulation cascade to stop them making clots. And so they need the big guns to stop clots. And at the moment, really, the only big guns that we have are warfarin, and sometimes people end up on low molecular weight heparin for a period of time. But that's the APS group, which I suppose is a kind of a second category in my mind, and again overlaps with all of the other categories. I'm going to then go to the categories that are slightly outside of lupus but very closely related, and that's our patients who have Sjogren's. So often the patients who have lupus will have a secondary Sjogren's on top of that. So that's autoimmune dry eyes, dry mouth, often associated with that Rho antibody that we previously mentioned, and photosensitivity or sensitivity to the sun. Sjogren's patients get different spectrum of disease. They can sometimes get lung involvement. They again can get inflammatory arthritis. And it is a common comorbidity that my patients with lupus will have a secondary Sjogren's with that. They can also have overlapping diseases with, say, scleroderma. So generally speaking, lupus plus scleroderma, the term we use to describe that is mixed connective tissue disease. And they can also overlap with rheumatoid arthritis. And we kind of unofficially call that lupus, but it's lupus with rheumatoid arthritis. And they will have an erosive deforming arthritis associated with their lupus, and often antibodies to rheumatoid factor and CCP along with their lupus antibodies. And what we see is that people who've had an immune system where they make one fundamental mistake, and that's the development of antibodies against themselves, over time they sometimes kind of pick up multiple mistakes, like a kind of a sloppy driver, you know. First you start forgetting to use your indicator, and then over time you make more and more mistakes. And the immune system is the same as that there is a kind of a drift over time where people with autoimmune disease will often go on to develop subsequent ones. Yeah.
The whole issue of gender differences when it comes to lupus, and like we know that more women live with lupus than men. Can you tell me a little bit about that and why that might be the case, or what do we know about it?
Yeah, so it's really interesting. So we think about 9 times more women than men have lupus. So in any lupus clinic, and my lupus clinic is reflective of this, there will be some men there, but the vast majority of the patients attending will be female. There's a couple of different kind of, it seems like the X chromosome carries risk factors for autoimmune disease, and historically they think that that's because our women's immune system have to be modified for them to be capable of carrying a pregnancy. So if you think about a baby will be 50% someone else's genetic material. And in a normal course of events, our immune systems should get rid of any material that doesn't belong to us. So say if you have a tapeworm or you have something, your immune system should recognize that and cause an immune response to that. And so our babies that we carry are 50% not ours, and yet our immune system tolerates their presence.
Yeah.
And the reason our immune system tolerates their presence is because women have different immune systems to men. And because of that, it seems to be that women are much more likely to get kind of hyperactive immune systems and then present with autoimmune disease. And that's pretty much true across the entire spectrum of autoimmune disease. So you see more thyroid disease in women, I see more, most of my diseases, the exception of maybe ankylosing spondylitis, I see more women presenting with the diseases than men. And so in lupus specifically, some people will say that it's the effect of the X chromosome, because if you look at men who happen to have two X chromosomes, so there are these kind of Klinefelters is what's that called? They have quite a high incidence of lupus if you have two X chromosomes, but you're a man. So if you're an XXY, they have quite a high incidence of lupus. Men who have low testosterone have a slightly higher incidence of lupus than the general male population. So maybe testosterone has an influence there. But it's going to come back to estrogen. Like, God almighty. Estrogen in our system seems to also lead us open to autoimmune disease. And so there's probably multiple factors that prime women for more autoimmune disease than men. But most of them are the differences that allow us to carry our babies and have been, I suppose, a positive influence on the survival of our species. But the price that we pay for that is that women get more autoimmune disease than men.
Yeah. And then in terms of I suppose the age of diagnosis, certainly it would appear that that kind of childbearing age is kind of the peak age of onset for lupus. I mean, do we know anything why that is the case? Is it again related to estrogen and
a combination of factors? I think it is the amount of time that people have been exposed to environmental pathogens by the time they hit their teens and 20s. Perhaps there seems to be a peak in kind of viral infections throughout the teens that might also trigger. So EBV, for example, and those kind of viruses. We often come in contact with those as teenagers, but it does have a big peak in presentation of lupus in the late teens and 20s and throughout their reproductive years. It becomes really problematic. And then I suppose it's massively important to my patients when they're planning their pregnancy, because the last thing that I want is for them to elect to be childless because they think their disease will have a negative impact on the next generation. When the truth is, I feel like my lupus clinic is full. I feel like they're more fertile actually than most. I have lots and lots of babies coming into my clinic, and I love it when people bring me their babies. But part of that process is that my patients will come to me before they're pregnant and they will say, I think I want to have a baby next year. And they have to be part of a process where they're talking to their caregivers and they're saying, what needs to happen with my medications? Is my disease quite enough for me to consider that? Some of them I will send to obstetrics before they get pregnant, so that they can have a discussion regarding what will my pregnancy journey look like? What can I expect? What are my risk factors here? Now, oftentimes when somebody hasn't yet had a baby, there's so much unknown out there because, you don't know how their body will respond. You don't know what kind of baby they're going to grow or what they're going to get. You don't know how labor will go, how their immune system will respond, how they'll respond to changes in their medication. There's so many unknown entities for my patients. But what we do need to do is that make sure that as they go into that pregnancy, the controllables have been controlled. So we want to have a conversation and say, my meds are compatible with pregnancy. I am on the right medications. These will not harm my baby and they will control my disease, please God, for the duration of my pregnancy. I know that I'm in the hands of a sensible person who will refer me to a high-risk clinic in obstetrics. We then need to look at the antibody profile of the patients. If the patient has a Rho antibody, there's about a 2 to 4% chance of their baby getting a thing called congenital heart block. And so now I should flip that on its head and say it's a 98% chance that baby won't get congenital heart block. But generally speaking, the Rho positive women will be followed in a specific protocoled clinic where their babies are screened for congenital heart block. So their babies will get ECGs, cardiac echoes, they'll be on a pathway. It's a really common antibody, it's a common pathway in obstetrics. So the Rho antibody, we'll want to know about that. We want to know about phospholipid antibodies and whether or not this patient has APS. There's a particular subtype of APS called obstetric APS, which is where the clot-making antibodies become active or are most problematic to this person in pregnancy. And there are some people who will just be anticoagulated for the duration of pregnancy, and outside of that won't require anticoagulation. So we need to ask about whether or not they have antibodies that cause clots. And then we need to look at their kidneys, because the one place that we know does a lot of extra work when someone's carrying a baby is their kidneys. And so the blood flow through the kidneys when you're sustaining 2 lives versus 1 the increase is massive. Yeah. And so if lupus is going to flare in pregnancy, it's not generally rash or arthritis that they present with, it's nephritis. And the problem with nephritis in pregnancy is that it can look very much like preeclampsia.
Right.
And so that becomes a difficult kind of decider. But the easiest way to decide between nephritis and preeclampsia in pregnancy is to have been following that patient and their blood tests over time and know what normal looks like for them, know what their complement levels look like, know what changes are normal in pregnancy, and then we can distinguish the two. Because if somebody has nephritis in pregnancy, we treat that with immune suppression. But if somebody has eclampsia or preeclampsia in pregnancy, we take the baby out. That's the treatment for that.
Sure. Yeah.
And so those are very different. And sometimes that can be a little bit tricky. We know that women who have lupus will commonly have slightly smaller babies than the general population. And we know that it's common for them to deliver those babies a little bit early. So we often will have that conversation with them. And then really it's going to be a matter of, cross your fingers and toes and hope for the best. You in a good centre where obstetrics are going to take good care, on good meds, good control, good compliance with your medication, and then go for it.
So talk to me a little bit about adherence to medications. We're talking about very, in often cases, complex disease. Treatment can be tough. Just tell me, how important is adherence to treatment regime?
I feel so sorry for my patients because I give them quite a significant burden of homework to do, and I acknowledge it's so hard to be on top of your medications and your appointments and all of the things that chronic disease are bringing along with them. So I'm going to say, for example, Gráinne, if you came to me with a new diagnosis of systemic lupus, I would be saying to you, so I need you to take hydroxychloroquine. You can take 2 tablets once a day. That's by far the easiest thing, and that's step A. So you're taking 2 Plaquenil. You can take them in the morning as you brush your teeth. You can take them in the evening. I don't care when you take them. I would like you to take them. Whilst you're on your hydroxychloroquine, we will organise an eye check at baseline to make sure that your eyes are healthy and that you have no problems with the back of your eyes. And then generally speaking, every couple of years, you'll get a screening test to make sure that there's no ocular or eye deposition of the hydroxychloroquine. The vast majority of people are on hydroxychloroquine for many years without any problems, but I do keep an eye, excuse the pun, on the ocular screening. So that's the first part. If you were then to develop subsequent inflammation of a system, be it joints or whatever it was, you would be building on the hydroxychloroquine therapy. So you start off, you come to me, you get 2 pills once a day. You then, for example, end up on methotrexate. So methotrexate is perhaps 8 pills that you take on 1 day per week, and the following day, generally speaking, you take folic acid. That's a second layer of complexity to your care. And now that I've added in an immune suppressant, you'll be getting regular blood tests, which will be appointments in the post every 8 to 12 weeks whilst you're on this therapy. So that's a second layer of complexity for people who have a job, kids, a life. That's tough to take. On top of those blood tests appointments, you'll have appointments to come back and see me on a regular basis. So there'll be that to be added to your schedule. If you were, for example, to develop nephritis, you would have your hydroxychloroquine. You wouldn't be on methotrexate, but you'd likely be on mycophenolate, which is a twice-a-day dose. Some people will end up on a TDS or 3 times a day dose, but for most people it's twice a day. Whilst you're on that therapy, you will get regular blood tests and you'll need to have those done. You'll be seeing likely a kidney doctor and a rheumatology doctor, so you'll have those appointments to navigate. And we'll be testing your urine when you come into the outpatients department. We know that from the perspective of nephritis, one of the strongest predictors of success and that the disease will go into complete remission is that the patients take their tablets. And I say that not at all wishing to be kind of paternalistic about it. And I totally acknowledge how difficult it is to get the multiple strains of kind of chronic disease and pull it all together. But when somebody has an internal organ that's inflamed, we are kind of honor bound to follow that really closely. And there is a kind of a quid pro quo on behalf of the patient where I really do try to say to them, you know, in 1 year's time when this is quiet, I will try roll this back. I will roll this back to the bare minimum of medication for you, but I need you for the sake of your ongoing health to commit to this therapy. And it is the thing that will often mean that you don't need to have more complex medications down the road, that you can keep away from the heavier, more chemo-like therapies. And so I really do beg kind of adherence, and I don't even like that word, but I suppose engagement in both directions so that people take their tablets. And I know it is a really complex and difficult thing to do, and sometimes we don't make it very easy for them. Navigating healthcare in this country, and I'm sure it's the same in every country, can be really complex. And if you're a person who's never been sick before and all of a sudden you come to a clinic and you get a big red diagnosis, and then you end up with multiple layers of medication when perhaps you're in college or you've just started working and all you want is a normal life, I can completely understand how you can push it to one side and say, you know, I want to go on holidays with the girls, I want to do whatever. But it is the onus is on the patient to get those tablets into them. We know that about 40% of the prescriptions that are written in this country never get put into the person's mouth. So I acknowledge that there's a high chance that lots of the scripts that I write at home or that I write when I'm in clinic never go anywhere. But I really want my lupus ones to be taken by the patient because I'm really invested in how they do and I want them to do well. So yeah, it can be quite a complex regimen, but the thing that predicts how somebody does is their attendance in outpatients, their attendance for their blood tests, their commitment to their medication, and it is, I am acknowledging that all of those things are a very big commitment to people who have already busy lives. But I suppose the take home is that they do really well, that when you commit and take your tablets, we tend to get it right and it tends to go really well. And that's also a really satisfying thing for the patients. So I totally recognise that it is horrible to have a chronic disease and to be constantly reminded of its presence. But if there is one thing that I would ask of my patients is that they please take their medications, because I know that down the road that equals health for them, that, you know, that things will settle down and that having them on board and having the right medication in their system is how we get to a good outcome.
And if I maybe move on to asking you just about some of the, I suppose, the side effects of lupus. And I know, you know, one that we would receive queries and questions around is around hair loss. Can you tell me a little bit about that? Because obviously, you know, that's a big impact in terms of a person's identity.
So there's a couple of different ways that people with lupus can lose hair. So I suppose the first is that people can get discoid on their head. So if you get discoid lupus rashes are kind of circles, they tend to cause circular areas of alopecia or hair loss on the head. So we treat discoid if it's on the head. Often we will do steroid injections into the areas of discoid, and then we'll start people on hydroxychloroquine and subsequent immunosuppressives if needed to treat the discoid. The other thing about discoid is, as I've mentioned before, it's exquisitely sun sensitive. So we will be asking them to cover up and making sure they don't get any ultraviolet exposure to their head. That's the discoid hair loss. The second kind of lupus hair loss that we see is you can get like a generalized hair thinning in any chronic disease from kind of disordered hair kind of cycling. And that's called telogen effluvium. And you get a generalized thinning of the whole head with that. And generally speaking, that reflects intercurrent illness. If your system is sick or your thyroid is a little bit off or things are not right, that can be a kind of a generalized thinning that happens. There's no magic wand for that. There's a lot of hair supplements out there. There's a lot of people making a lot of money off those hair supplements. In my world, that tends to improve when we get disease control. Yeah. It also tends to improve when people get off corticosteroids. So when the steroids are gone, that tends to also improve. So that, I usually hang tough on the therapies and things will get better. Lupus alopecia specifically mirrors a little bit the hair loss that people have after they've had babies. So it tends to be the kind of front of the head and going up through here that people lose a kind of a crown of hair. And that can reflect lupus disease activity. And again, gaining control of their lupus can help with that hair regrowth. I suppose there are lots of other causes for hair loss that our patients are not immune to, but the lupus specific ones do tend to improve once we get control of their disease. So once their immune system has been knocked off, generally speaking, you get nice regrowth of the hair. As the hair is regrowing, it tends to be exquisitely kind of weak, like baby hair. And so it's one of those things that we ask people to be really gentle with their hair and to make sure that there's no traction put on it. Because one of the things people will do when their hair is thinning is that they may add extensions to the hair, and often the addition of an extension to kind of a weak hair root will pull it off. Okay. So they have to be careful. They can get grants for hair pieces and wigs if needed and other forms of hair covering, and they've really improved over the years, and really some of them are quite beautiful. But people don't really want those. They want their own hair. Yeah. And so I think it's worth exploring those kind of options if you need to, because people need to get out of their house. People need to, but I do hope in most instances with control of disease, things kind of situation improves. The hair will grow back. Yeah.
Okay. The other side effect, I suppose, that I wanted to touch on was the whole area of fatigue.
Oh, I know.
Because that's the other one, if I was to call out the other one that we get a lot of queries on, fatigue and its role and how that interplays with lupus and what can be, done to manage that, because it has such a huge impact on the lives of people living with lupus.
Yeah, so it's hard. So I suppose I'll start by saying that everybody will say that they are fatigued. So no matter who you talk to, they will say on any given day of the week that they suffer from fatigue. But the fatigue that people who have chronic autoimmune disease have is a completely different phenomenon. So they are carrying around a jacket made of stone. They are absolutely flat, and their bodies are working really hard against themselves. So it's a different type of leaden feeling that those patients have than, say, the general, like, oh, I was up early this morning kind of feeling. And I think what happens is in their own lives, people get tired of hearing about that. Their family members, their friends, they think, oh, everyone's tired. But that's not what they're describing. They're not describing an everyday tiredness. They're describing a leaden feeling within their bodies that is something they have never experienced before. It's totally different. I would love to say to you that I light bulb switch and that goes away, because it doesn't. But there definitely are things that make it better. So the first thing that I will say is that, and I should have probably mentioned this before now, is that cortisone is not their friend. So chronic steroid use is really common in patients with autoimmune disease, because we often will use it as a bit of a crutch to gain control of organ inflammation. And the payback off the far side of that, while you're bringing the steroids down, can be quite significant. So some patients will get very depressed on the steroids, others will be high as a kite, they'll feel amazing, but they crash on the far side, and that can be a really difficult one to kind of clamber their way out of. So steroid minimization and avoidance of excessive doses of corticosteroids is a key component to the management of lupus. I don't want them blasted. Unless they have to be. The roller coasters of ups and downs that chronic steroid use causes in your system is really hard to deal with. It also causes muscle loss. It causes bone loss, poor sleep. It often is a kind of a trigger at the start for everything just falling apart, The second thing that I'll say is there is data across autoimmune diseases in general that gaining control of inflammation can help fatigue. So it does help to kind of gain control of that big inflammatory surge that's attacking your body. And I suppose that the other thing that helps, and nobody ever says this, is like being as strong as you possibly can. So having your maximum muscle bulk, thinking about whether or not you need to lift some weights. How do you maintain yourself? Because you will wither away with steroids, and it's so hard. And then it's the cycling of sleep, and it's how do you get on top of a really healthy sleep-wake cycle. So, and I give them medications all the time that mess with their sleep-wake cycle. So people will be on tablets that interact with their, steroids are the classic one, but other tablets that interact with their sleep-wake cycle. And it can then be really difficult for people to click back into kind of functional sleep. So... And then there's things growing like, obstructive sleep apnea. They gain weight on lots of the therapies that we have them on. That makes their sleep worse. That makes the fatigue worse, makes the daytime sleepiness worse. I'm generally fine with people taking a nap in the middle of the day if they need to, but anything that you nap over, say, 30 minutes will cause you to fall into REM. And if you hit deep sleep on a nap, your body will not do that twice in a day. So if the nap has been your opportunity for deep sleep, the likelihood is that you then won't hit sleep that night. So 20-minute cat nap, totally fine to keep it going. And then a lot of it falls down to kind of scheduling and keeping to a really rigid routine with yourself. So whilst acknowledging that there is no easy answers for patients who have chronic fatigue, there are a couple of things that probably do make a difference. The first is steroid minimization if possible, depending on what their disease looks like. The second is going to be maintaining their physical fitness and strength insofar as is possible. And then the third thing is scheduling and making sure that they're on a really good sleep-wake schedule. And after that, it's really hard. But for the most part, the fatigue that comes with lupus does also settle over time. But there isn't one easy answer.
No, I think you explained it well, though, in terms of the combination of factors that can be considered. So thank you for that. As we move towards the end of our interview this afternoon, the availability of therapies, the landscape, I guess, for lupus therapies, and particularly the availability of therapies in Ireland, because obviously that's a role that Arthritis Ireland has kind of a key advocacy role in. And certainly, the understanding is that there are therapies that are available elsewhere in Europe, but they're not available in Ireland. So can you just tell me a little bit about that in terms of maybe what's lacking in the therapy space for lupus patients in Ireland at the moment?
So I'm going to tell you, without disclosing any patient information, I'm going to tell you a story of two sisters. So one of whom attends my clinic and one of whom lives overseas. And they have very similar lupus to each other. And the girl who is living in Germany has access to subcutaneous lupus biologics and is well controlled on those. And I see her intermittently when she's home at summer times or whatever, and she has been very healthy and well. Her sister lives in Ireland and does not have access, despite having the same, very similar spectrum of disease, does not have access to the same range of therapeutics that are available in Germany. And within their family, that's a cause for obviously upset, because they have two children who are having two completely different healthcare experiences by virtue of where they chose to go to university. And they very much highlight for me an inequity that exists in Ireland in terms of the access to therapeutic agents. So lupus has been, for loads of reasons, because it is probably 6 different diseases, maybe 20 different diseases. It's a really spread patient group. They're really different. It's been really difficult to develop drugs in this area. It's been really difficult to define success when we look at drugs in clinical trials. And so for a long time, there was nothing in the pipeline. There was nothing new coming on board in lupus. But in the last decade, there are new biologic agents that target antibody pathways in different ways. And they look great. They look like nice options for people who have for example, skin disease. They look like nice options for add-ons in people who have kidney disease. They don't look like that they're a light bulb that turns off lupus, but nobody has ever thought that. But they are really effective therapies that those two sisters have totally different access to. And I suppose I look at my lupus patients and I want them to have the best available. I want them to have first world therapies. And at the moment, they don't have access to first world therapies. And that makes me sad. And so I'm hopeful that those will be approved in due course and that they will be options for my patients. And that I won't be low grade mortified talking to a family about why their two daughters have different healthcare journeys based on their
within
geography.
the European Union as well.
Exactly. Yeah.
I think that really highlights the issues we face with I suppose reimbursement decisions and authorization for therapy. So thank you for that. And I suppose, look, lastly, can you just talk to me a little bit about the future for lupus patients, what that might look like, and maybe in terms of research that's happening, I suppose that element of hope that's on the horizon for lupus.
Yeah. So I'll start by saying I feel like my patients for the most part do really well. I think they're dealt a horrible card, but I think in lots of ways we do really well in lupus. And it used to be a thing where patients were diagnosed with lupus and they were paternalistically dictated to that they couldn't have babies, that they shouldn't expect a normal life, that that it was a very miserable sentence to be given. And my patients have a full expectation that they have a normal life. And I really want that for them. So I want them to take their chronic disease, take their pills in the morning and walk out and have their jobs and their families and the normal day-to-day stuff that challenges us all, and for their disease to be in the background. So over the last 50 years, the landscape of how we interact with lupus and what we think about lupus is totally different. But we're slow to develop drugs in the area. And I suppose we're also slow to kind of predict what kind of lupus each person has. And so what I would love is for us to get a better definition regarding who's going to get what. So at the moment, I have a bag of M&Ms and they're all different colours. And each person looks a little bit different. And ideally, and I think what we're working towards is a scenario where we can stratify people into groups and we can say, well, this person, this is likely to be a nephritis. This is where she's heading. Kidney inflammation is in her future. Let's see if we can intervene early and either prevent that or get it at the very start. Or this person is going to go on a pathway that looks very similar to rheumatoid arthritis. How do we optimize that therapy early so that we prevent any chronic disability as a result of that? And so on and so forth for the skin and the hematology. And if we could find a way where we could predict from the offset, be it based on their antibodies or what they look like, or perhaps the inflammation signatures that are in their blood, what camp they land in, it would be really great for that patient to say, this is the likelihood that you're going in this direction and this is the therapeutic pathway we need to put you on to stop that happening. And that's what I would love for them, because I look at people who come into clinic to me and I see their bloods and I say, I'm waiting for nephritis. I know that this person is heading for nephritis. And that feels like a really helpless place. And truthfully, Grania, some of them do exactly what I expect them to do. And within the year, they have a positive UPCR, they're on their mycophenolate, they have their nephritis. But some of them, although they look like they might get nephritis, it doesn't really happen. And I'd love to know what was different between those people. And I think the markers are in their blood if we could just understand a little bit better what the processes are. So I suppose I think that the future in lupus is going to be better categorization and then targeted therapies according to those categorizations.
Okay. Well, on that positive note, I think we'll finish up this afternoon. Laura Durcan, thank you so much for spending time with us
it
and
was a
answering
pleasure.
so many questions. Thank you so much. And thank you very much for watching. For more information about lupus, please log on to our website, arthritisireland.ie. You can also get further support via our online Facebook groups or our helpline 0818 252 846. Thank you again to Dr. Laura Durcan for joining us and for sharing her insights and experience. We look forward to seeing you all again soon.